But to your point, I think that's really important to recognize is that, a lot of times you don't see, especially someone who's just coming in with maybe not a long history of their eating disorder or not as severe, a lot of lab results that are abnormal. At most, I might see a little bit of iron deficiency. Like that's like the touch of it. Hi, welcome to the RD Roadmap, Journey to Eating Disorder Expertise. This is episode 9, Navigating the Rocky Path of Medical Complications, part 3. We keep going and going. My name is Jill Sankey. I'm a registered dietitian and one of your tour guides.
My name is Mateus Milhomes, a registered dietitian as well.
Well, we're going to dig deep into hormones, a little bit of blood sugar, possibly, as well as thyroid issues and concerns that can pop in. So we have a lot to talk about, but thought we would start with this portion with us talking about a little bit of like when you're hiking, like what's in your backpack. What are those things that you need? What are the essentials? And I think sometimes like laboratory values and knowledge really feel uncomfortable. You feel, it's hard to really know what to look at and navigate with. And so we wanted to kind of give you some empowerment of like, what do you need to be packing in that backpack and how to use some of these tools outside of just the labs, but also what you see in session, right? To clue you in, to dig further, or to even ask a physician, if you don't even have any sort of physician on your team, what labs to be looking at. And of course, we're not ones that are the diagnostic criteria individuals or the individuals that interpret labs to essentially say XYZ is happening for the most part. But I think it's important to feel more comfortable of knowing what's in that backpack when you hike, so that you're really looking at the big picture instead of just a few things that the client's expressing or saying, and you're kind of in the blind a little bit. I keep thinking about my sister-in-law, my sister and her husband went with their future daughter-in-law for a hike out in Colorado where I live. And they were talking about their hike. It was really pretty, but we had to turn around because we didn't bring water. I'm like, I don't care if it's a 15-minute hike or if you're going on a hike, you need basic water. So, so I thought we can kind of dig into the labs. Like, what are the basic things you want to have looked at or asked for, and then how to interpret it and look at it so that you really are most confident on that hike that you're going on, regardless if the weather's cool or not. In Colorado, you can get dehydrated really, really quick. So I don't know if that's the best analogy, but I thought I'd go there. So,
Yeah,
Mateus, thoughts
no,
about that?
Colorado is a place that when I go, it's like I'm a camel. Like I'm drinking water left and right, and even drinking tons of water and not doing anything in particular.
Yeah.
I'm like struggling,
Yeah.
you know. I think that you bring up a good point that while we can't make diagnosis, I don't know what dietitians can't make diagnosis based on labs and stuff.
Yeah.
I think that we through training, we are probably one of the most empowered healthcare providers, when it comes to malnutrition is we need to be malnutrition experts too. I think that there's a shift and a focus on larger bodies, overweight, obesity, and things like that, and how to navigate those things as if malnutrition doesn't exist anymore in the US because the population
60% of us are,
shifted.
quote obese, right? Yeah.
Yeah.
Mhm.
So I think that people can be good at looking like, oh, you have high LDL, you have high glucose and things like that. But when malnutrition indicators come around, it can be met with a little bit of confusion, you know. Um, and I think that knowing how to interpret those can help guide the client, because I can look at the thyroid hormones, and while I can't make a diagnosis, I can tell them like from a malnutrition perspective,
Mhm. Mhm.
this is some things that we see often, and these are some things that can be helpful and some things that can make problems worse a little bit,
Mhm.
So I think that's a very important role that we play in healthcare for sure.
Mhm. Yeah, and then outside of even labs getting them, right, it's just what questions to ask in the room. What have there been any symptoms you're experiencing? Are you having any night sweats? Are you having any soreness when you wake up? Um, do you have a lot of fatigue? Outside of just maybe not getting enough food in, kind of asking certain questions in the room and in the first um, the initial assessment and the subsequent follow-ups can also help you connect all the dots together. Just looking at their hands, maybe giving them a handshake and noticing how cold their hands are. Or like we talked about the nutrition focused exam, a little bit of like muscle loss, but sometimes like, kind of discoloration in their fingers, right? A little bit of the purpleness and they're not having really adequate blood flow. Those are various things that we can do that kind of connect the dots to laboratory and then eventually to the malnutrition piece of it, which is really the theme of what we've been talking about for several episodes at this time.
Yeah. Changes in hair quality, thinning of hair, cold intolerance, things
Yeah, are
like
you
that.
noticing a lot of hair loss? Have you noticed more thinning? Those things. So we, outside of just the labs and information, again, there's tons of resources that you can look at. We're hoping to connect the dots in the room too, so that you can be more confident in what questions to be asking and kind of interpreting. So yeah. Well, what for you on outpatient? I think you can have levels of people coming in, from someone who is, at the verge of their eating disorder and someone who's had it for years. So based on the amount of time you've been in the field, what is the worst malnutrition case you've seen? Maybe like what have you seen? Just to give perspective of like, sometimes you can see it in the first few weeks of beginning in the field, and sometimes it takes a year or two before you have someone walk in that you're like, oh my gosh, this is someone that's really in trouble.
Yeah. I think a couple of clients that come to mind that I think can be particularly confusing are younger clients,
Mhm.
because I've had clients that never had a period. Because I think that a client that's in their late teens and they had periods for a while and it stopped, it kind of raises concern a little bit more,
Yeah.
you know,
Mhm.
uh, directly, versus a kid that is 9, that now is like going to that time that the period should have started. I have a client that is 14 now
Mhm.
and still haven't had a period. So I think those can be particularly confusing because each person starts, menarche at, it's not like a set in stone time frame.
Mhm.
Um, and I see those clients coming with a lot of specialists on their team already, endocrinologists, um, cardiologists, it's a very classic picture of like parents have been trying to figure this out and getting medical input from various sources, and the malnutrition piece stays quietly untouched.
Mhm. Not addressed,
Medications,
not
trying
considered.
to figure all these things out. Yeah.
Mhm. Mhm.
So that's something that I see a lot. And I've seen boys too that um when we got blood work done, testosterone was just like
Non-existent.
n- not non-existent.
Mhm.
And then the impacts that it has on not only muscle mass but bone density and things like that. And I think those clients, the clients that I'm thinking about, are all very young.
Mhm. Mhm.
So you kind of match um that confusion, because it's like on that limbo of being a kid and being a teenager, the prepubescence kind of like space that can be very confusing for providers and for the parents as well. What about you?
I keep thinking
I know
of,
you've had experience with like some older clients too, and like things like that.
yeah, I was just thinking that, like, in a way, I've definitely, I've been in the field for much longer than you have, and so I've definitely have experienced, 9 and 10-year-olds coming in, or adolescents that had their cycle and then it stopped, right? I keep thinking of those that are older, and so I'm thinking of a male that I worked with that was, had an eating disorder for a very, very long time. And essentially getting his DEXA scan, and he had close to a -4 on his score. And it was just, I couldn't believe it, and that's just the length of time. Or I'm thinking of another woman that I'm working with that's quite much older, probably in her 70s, and she had to get all her teeth capped, right, because of kind of purging that she engaged in, right? So she really had no more teeth, left with her. I know we're talking about hormones and things like that, but just in terms of like the impact of malnutrition on the bone, for example, I used a couple of examples there of where they walk in and they don't look overwhelmingly malnourished, or they look more normal per se, or average, I'd say, but they are definitely still quite emaciated with pretty significant negative impacts. Or even another male that I worked with in his 20s, that he was taking testosterone supplementation, frustrated with, his sex drive and things like that. And he clearly had an eating disorder associated with that, and that wasn't really being addressed. So I always think of Dr. Mailer, and he always talks about like, you need to rule in the eating disorder first, which I think a lot of times you don't see that happening with providers, unfortunately. And so I know many of those that listen to this podcast are probably outpatient providers. So we want to validate that frustration that typically you're not going to oftentimes work in a full team, or, have to kind of carry that medical burden, which can feel really uncomfortable and scary. And so we want to give you a little bit more confidence in this to navigate and feel like why you need to be looking at this and asking for it, and not necessarily leaning on the inexperienced physician with eating disorders to determine what that interpretation needs to look like. So that can be scary because it feels like you're not on the same page with the physician that you're working with. I don't know. I experienced that a lot too. I don't know if you've experienced that with non-eating disorder provider physicians, really minimizing
Yeah,
their symptoms.
I've had some, and it's interesting because I definitely had the experience of, you know, being dismissed a little bit.
Yeah.
And I had the experience of the provider being like, I have no clue. Just tell me what to do.
Yeah. Yep.
Tell me
Got that too.
what labs to order. I'll do whatever,
Yeah.
And so I've had that experience too, which I think is nice, to be able to recognize that it's just not your area of expertise, and still try to help, and make space for extra support and stuff.
Yeah, no, for sure. And then just encouraging the frequency of lab monitoring, and so I think that can be uncomfortable with, I've had a physician, I'm thinking of one family, I worked with an adolescent that had lost their cycle, was struggling with hypoglycemia, and the physician was so in doubt of her having low blood sugar that she required the mother to go into a hospital so they could have immediate results in the hospital setting versus the outpatient, like maybe Quest or LabCorp, where they might take that and then send it in to get evaluated, but to have immediate results, because the physician was like, there's no way that this person can have low blood sugar, this child. And she, should have been 140s but was all the way down to 95 pounds, and so, yeah, she was in this age group that when she was 95 pounds, looked more of that lanky, skinny kind of adolescent girl that you're like, oh, they just haven't gone through puberty yet. When in reality, she had just lost her cycle. So that's another frustrating thing, is like the physician just couldn't buy in to the concept of like, yes, the low blood sugar is definitely part of her eating disorder. And so I was trying to get them to do like a continuous blood glucose monitor or something, and they just, she wouldn't go for it. So
Yeah, I had a similar experience with ER visits,
yeah,
that the client tells them that they have an eating disorder, and they look at the client, they're like, you don't look like you have an eating
yeah,
disorder. Like, what does that even mean? And I find that dismissiveness to be particularly complicated with clients in larger bodies, because I have clients that are in larger bodies and they get decompensated while still they don't have to lose copious amounts of weight
Mhm.
to get, low blood sugars and shaking, trembling, dizziness, and all those things,
Fainting. I was working with someone this week who's like, very much engaging in restrictive eating and over exercise in a larger body. And she's like, yeah, I fainted. I'm like, and hit my head. I'm like, okay, we need to talk about this type of thing. So, yeah, so it can definitely happen. So, yeah, so we're on the back end, we're going to dig into some of the labs, hormonal based essentially, and really give you more empowerment and understanding of how to, what to be packing in that backpack as you go hiking down this pathway to this journey on your eating disorder knowledge base, and then giving you tons of resources to look in more in depth with. I encourage you, for at least the dietitian, and we may have some therapists here as well. For therapists, encourage you to really lean on the dietitian. They have a lot of knowledge base on, the medical complications as well as the laboratory interpretations, et cetera. However, if you're a dietitian newer to the field, I know I started in clinical. I wasn't looking at malnutrition and labs for malnutrition. I'm sure I saw many of it, but didn't realize it. I was looking for, other things that might be related to just overall sickness or things like that. Not in terms of the eating disorder. I definitely, we would look at way back then it was albumin or pre-albumin, which is really now we know is like not really the best indicators of things. So it's just now that we have such great research and knowledge base on eating disorders, there's a lot of laboratory values and bone stuff and all of that we can, hormones like sex hormones and things like that we can really look into, and give us a little bit better sign of we're probably looking at like medical starvation, versus like, something else. So anyway, so for the dietitian that's newer to the field, getting you reacquainted with labs again, and maybe in a different lens and looking at things so that you feel a little bit more confident of what to be asking for and how to look at things. So,
Yeah.
all right. Well, we'll see you in the back end. Thanks for joining.
Thank you.